Okay, welcome everybody. We are here at the end of the session about coronary physiology, new insights. I'm sharing here the position with Jung-Min from Korea. Our guests are Dr. Collet from Belgium, Dr. Koo from Korea, and Dr. Fearon from Stanford. It is a pleasure to have here a short discussion, and I would like to start with Carlos Collet. Carlos, you had a nice talk about PPG. In that talk, you were mainly discussing the use of PPG to put an indication to see if and how disease should be treated. Can you also say a little bit about PPG after PCI? Does PPG before PCI predict what's happening after PCI?
Yeah, so thank you, Nico, for the question. And I think we had a very nice session. And what is becoming very clear is that physiology is becoming more relevant than ever. I think you and Bernard developed the field basically trying to answer the question, is this lesion significant, is this lesion non-significant? And that really opened the way of all these new assessments that you mentioned, like the PPG. Now the way that we have expanded the use of physiology is not only to understand whether it's significant or not, but also what is the best treatment for that particular patient based on the distribution of pressure losses. And we make very clear during the session that we have cases with focal disease that are very good for PCI. Post-PCI fractional flow reserve is very high. And we have seen that we cannot treat diffuse disease. So if there is something that we have learned over the last 3-4 years in this study of PPG is that we are very effective treating focal disease, but we cannot improve blood flow with PCI in patients with diffuse disease. And I think that's the major take-home message in that regard.
Okay, thank you very much. Jung-Min, you would like to ask a question?
Oh, first of all, I like to congratulations on the winning the Masters of Masters award this year at TCTAP. So actually, first of all, I'd like to ask you, what is your feeling? It is a long journey of 30 years of physiology journey. So could you tell us what's your feeling?
For the physiology, the development of physiology,
yeah.
Well, I think it will be increasingly important. And I think our possibilities to describe fully the circulation of the heart is increasing. We had FFR, which was very fine for epicardial disease. We have expanded that with the PPG, which refines it a lot. And now we have also good measures for microvascular disease. We relied first upon CFR, then Bill Fearon came up with IMR, which was a great step forward. And now we can even measure, separate the flow and resistance in the myocardium. Mm-hmm. So for my feeling, we have progressed a lot. Yeah.
I think the FFR is very important because the beauty of FFR is we can avoid the unnecessary procedure. In addition, if FFR is very low, we can improve the patient's symptom if we treat it with a stent. And PPG give us the very important clue that who will be the most benefit from the coronary intervention. I believe that. In addition, many experts developed a new technology to evaluate the microvascular dysfunction. So in my clinics, I met many patients complain of chest pain, but without any definite causes. So in the future, we will define the patient and we will give them the better care, I think.
So I think that that's a very important, kind of accomplishments we should do with the physiologic assessment. Yeah. Patient outcome and patient vulnerability. I'm saying that because many have prejudice or bias that vulnerability is the realm of imaging. And there's nothing we can do about vulnerability with physiology, but if we interpret the vulnerability and expand it into the patient vulnerability and open your eyes, look in the data, there are lots of evidence that physiology is more important in even lesion level vulnerability and also the patient level vulnerability. And as we discussed in the previous session, that the pressure gradient itself is not a simple delta FFR, but it's a kind of mechanical stress to the plaque, and plaque is exposed in each minute to that stress. And I think in that perspective, association between PPG and plaque vulnerability, and recent paper in JACC imaging is very important to open and extend that kind of, concept, physiology versus vulnerabilities. How do you feel?
So I think we need to expand the slide of Nico for the next 50 years. But what is becoming clear is that this is a moving field, and it started with the development of the pressure wire that makes measuring pressure very easy. And now we have refined the way we approach PCI based on the pullbacks. And what you're saying is basically the next frontier of physiology to help integrating all this information in the context of the vulnerable plaque. And I think this is a field that will grow in that regard.
Yeah, and I think sometimes people get confused and they believe the sort of old story that mild lesions are the ones that are most dangerous and the ones that cause most MIs. I think we now know and understand that it's actually the more severe lesions with the high pressure gradient that are associated with greater plaque vulnerability and greater risk of MI. And so certainly using physiology to help guide us on which lesions require revascularization, I think is more important than it has been ever. But I do want to ask Jung-Min about the PREVENT trial, because I think that's a really exciting study that's, a lot of talk going on about it. And just to get your sense of, this field of plaque vulnerability, how do we, integrate the results of that study into our daily practice?
Yeah, very important, but a very difficult question. But I believe that the coronary event is equal to the plaque multiply flow. So flow is associated with mostly patient symptom. Plaque may be associated with the abrupt event, plaque rupture, something like that. So physiology can evaluate the flow itself, and imaging can evaluate the plaque. And so if we evaluate both the plaque and flow, so we can give patient better patient care. Return to the PREVENT trial, that is based on the current data, it's not easy to apply in our daily practice. So we need more criteria for high-risk plaque definition, because even though PREVENT trial show that the positive result, but the positive predictive value for high-risk plaque is very low still. Overall event rate is very low. So in the future, we need better imaging and physiology definition of vulnerable or high-risk plaque. That is the one thing. The other is we have to do very event-free, very safe PCI if we want to treat the vulnerable high-risk plaque, if the FFR is negative.
Yeah, and I wanted to ask Kwon about that idea of identifying vulnerable plaques. Doing 3-vessel intravascular imaging, routinely doesn't seem like a great solution. How do you see non-invasive techniques like CT evolving in this area?
Yeah, so I fully agree. So 3-vessel FFR, 3-vessel IMR, 3-vessel OCT, it's possible, but practically not feasible. So I'm learning a lot from the CT studies. So for the PREVENT trial, so our previous analysis showed that the plaque, kind of high-risk plaque characteristics matters, but if it really caused a statistically significant difference among the high FFR lesions, it should be quantity, quality, lumen small, plaque burden high, and very vulnerable plaque. So one of them may not be enough. So that I think that's also can be reproduced in the PREVENT trial. It's really a hardcore lesions, 96-7% lumen less than 4, plaque burden 70%, but event rate at 2 years is less than 4%. And if you see the symptom, at 2 years, deferral patients have a numerically better symptom than the PCI. So that's what we're saying, that there's a data, so define OCT, data that the high FFR vulnerability, it matters, but to define the vulnerability by imaging, lumen is not enough, burden is not enough, characteristics is not enough. So combine all three together is definitely needed to show the benefit of. But the problem is that the prevalence of those are very small, so that the preventive PCI and all the assessment may not be cost effectiveness, so that the CT all-in-one strategy can provide the lumen, plaque burden, plaque characteristics, hemodynamics, physiology lesion distribution, and anatomical lesion distribution, so that we can have a better insight which can transform into our cath lab activities. So having said that, when we analyze our data, it seems that physiology is much simpler, either using delta FFR or the PPG is much simpler than combining all the metrics, so 40, 50 metrics from the imaging. So the question is, which is easier, physiology, imaging? Many people think that this is complicated thing, this is easy thing to do, but if you see the data, I would say that this is much easier to assess plaque vulnerability rather than imaging. But still, you can do that if you're interested.
Yeah, although I thought Gary Mintz's talk today showing that even core laboratories disagree, very commonly on what represents a vulnerable plaque and what doesn't. It was really enlightening. And the other issue is that they change, right? If we treat them with high-dose statin or PCSK9 inhibitor, they can become less vulnerable. And
right, so that
complicates it too.
In terms of vulnerability of that time-dependent changes, plaque character changed first, plaque burden and lumen changed the second, and delta FFR or the FFR is the last one that is changed by the PCSK9 and any kind of statin. So that's why I personally believe that the FFR or delta FFR PPZ is more robust than the imaging in terms of the vulnerability assessment for the patient.
Okay, going back to the microcirculation, what do you think when you are talking about FFR by CT? Will it ever be possible to determine also the microcirculation by CT PET, for example?
Yes, so that in the beginning, so we tried to assess the myocardial blood flow. So in a very early period of the CT-FFR development, we were very interested in the measurement of the flow, but somehow it wasn't that successful. So we forgot about those things. But the new concept MRR, which can be combined with the resting flow, hyperemic flow, and FFR, two different pressures, CFR. So I think that it can be also reproduced by the CT, especially with the flow information pad. So that will be another very important kind of area that should be pursued by the CT and flow studies. But it's not easy and complicated, maybe more complicated than the invasive continuous thermal dilation measurement.
Thank you, Bill. And one more question to you. You are the inventor, so to say, of IMR. It has been applied during 20 years with a lot of success. It has increased our knowledge. It has shown to have prognostic implications. What do you think about the new developments with absolute blood flow and MRR? How do you see that? What is your expectation about it?
Yeah, well, I think MRR is a very exciting new index. I kind of view it as a more refined CFR because it corrects for epicardial disease by taking into account FFR. And one of the big disadvantages of CFR is that it interrogates the entire circulation, and it's not microvascular specific. So I think that is one of the nice advantages of MRR. I think it provides, in my opinion, maybe complementary information to microvascular resistance or IMR. It gives you information on the vasodilatory reserve, which I think is very important, clearly prognostically important. There is still the issue of resting flow, and both MRR and CFR are affected by resting flow, and as we all know, resting flow is quite variable. So that's still one thing I think we need to figure out more, and whether people with low resting flow and a low MRR, I'm sorry, high resting flow, high resting flow and low MRR, is that really microvascular dysfunction, or are that just because it's an older patient with risk factors, kidney disease, other things that lead to high resting flow, and that's what's causing a higher death rate? I think we need to figure this out. But as you're aware, we've done studies looking at, particularly in the STEMI population, MRR and IMR, and showing that they're additive. They each provide unique information about prognosis, and the two together is even better than either alone. So, I think we're at the tip of the iceberg. This is a really growing field. We've got a lot to learn, but I'm very excited about it. And I think the thermodilution continuous flow technique is so elegant and so reproducible, and that's really going to help us, get even more accurate data.
Thank you. I wanted to switch a little bit now to the angio-derived NHS. You had a presentation about that. There was another presentation about bifurcations. Bon, you are in fact the great expert in the physiology of bifurcations. You already did work long ago, giving us much more insight about what happened in fact in the bifurcation during stenting of the main vessel and what happened to the side vessel, etc. How do you look at QFR in general and in particular to the application of it on bifurcations? Do you believe that it has a role, or do you say, well, that is so tricky at the moment that I wouldn't prefer to use it?
So if I have to answer yes or no, at this stage I should say no. So because that we have already known that the angiographic limitation, especially at the ostium of the jailed branches. So, and that's why there's a big discordance between angio and physiology, and any image-based physiology is literally based from image. So if there's a big limitation in image, so it will not be working. Having said that, one promising element will be that mu-FR, which use only one view, but it also have several limitations, so that the inventor of mu-FR to fix that issue now try to integrate OCT-derived osteal images combining with the angio, but technically it may be feasible. That's not the practical. So when you're approaching to more and more anatomically complex lesions such as bifurcation left main, I think that the accuracy of any image-based physiology gets lower, so that we have a certain range where we have some confidence in the image-based physiology. And I don't know the range, but maybe the bill can provide us better insight on that kind of range and the confidence.
Well, I think it's another difficult question to answer because we need more data. I feel like we're just getting some clinical outcome studies going, looking at the angio-based techniques. I think we'll learn a lot about how feasible they are in a broader range of patients. The studies correlating them with wire-based FFR have shown superb correlation, but of course it's been maybe select patient populations and select operators, and so these bigger randomized studies that are including a broader set of patients with more operators, I think will really help us understand, exactly how feasible and accurate and reliable these angio-based techniques are. But I'm optimistic, but we'll see.
Okay, we raise a lot of concern about the use of IFR and its reliability. We have little time to go, but maybe Carlos can say a little word about the use of a pullback curve by IFR, as is advocated at the moment, versus the PPG.
Well, I think that the resting indexes has really expanded the use of invasive physiology, and many of our colleagues that initially were not using FFR because of concerns related to the hyperemia or the time it took really approach invasive physiology with resting indexes. And we also need to recognize that in 80% of the times, these two indexes agree with each other, which is a lot. Now, in clinical practice, again, my message is very clear. If you think that there is a discrepancy or a false negative resting index-induced hyperemia, just inject contrast and you'll have hyperemia right away. And be very careful in proximal lesions and in focal lesions where this index can be negative. That's my advice. Now, concerning the pullback curve, well, it's not a surprise that when we compare the resting with the hyperemic, we find a correlation of 80%. So they agree in 80% of the times, with the caveats that I just mentioned with very focal lesions.
But I want to add to your comment. IFR, I think we have to measure the FFR, but we have to remember the IFR value or non-hyperemic pressure ratio, because combination of resting index and hyperemic index, we can differentiate the patient and the lesion physiologic characteristics and clinical characteristics. So it may affect the patient prognosis, something like that. So for comprehensive analysis of coronary physiology, we have to remember the resting index, and finally, FFR measurement is important, I think.
In fact, we are a little bit back 20 years ago. Then at meetings, it was often asked, if my resting PDPA is below 0.80, do I have to induce hyperemia? And I always said, no, of course, not for taking the decision. If your resting value is above 0.8, then you need to induce hyperemia. And I think that's particularly true in what you indicated in your slide, the proximal and mid part of the large coronary arteries. Okay, I think that we have to close because the clock says that we are over time. I would like to thank all of you for this very nice discussion, and I close this session hereby. Thank you.